Okay, it's 2 o'clock. So thank you all for coming. I know it's a beautiful day, but this is a topic of interest to all of us. So good afternoon. My name is Kelly Boyce Heimbaugh, and I proudly serve as president of the Chautauqua Women's Club. Welcome to our Contemporary Issues Forum lecture. We invite you to join us here at the Hall of Philosophy every Saturday at 2 p.m., and we have lectures through week 8. Next week, we are excited to present one of the highest-ranking females in the Navy, retired Vice Admiral Anne Rondeau, who is currently president of the Naval Postgraduate School in Monterey, California. Her topic title is Technological Leadership, Combining Research and Education for Advantage at Sea. Her lecture, following her lecture at 5 p.m., there'll be a wine and cheese reception at the Women's Club. Tickets are $25 per person. You can sign up on our website, chautauquawomensclub.org. And if you are a veteran and would like to attend at no cost, please go over to our membership table and register. You can spread the word. And this lecture next week is possible through the generous bequest of Ellie Haupt. For 133 years, the Chautauqua Women's Club has provided innovative programming, dynamic events, and leadership opportunities for women, and life-changing scholarships for students. Our leadership and legacy is one of significant influence, both on the grounds of the Chautauqua community as well as outside on society. To date, we have provided over $1.8 million to Chautauqua Institution in scholarships for students in the schools of performing and visual arts. Our influence can be seen on society through leadership of the women's suffrage movement, the League of Nations, the Equal Rights Amendment, as well as safe working conditions for employees. Our history includes greats such as Eleanor Roosevelt, Amelia Earhart, Sandra Day O'Connor, just to name a few. If you are a member of the Chautauqua Women's Club, we thank you and encourage you to get involved. Volunteering is the easiest way to make new friends. If you are not a member yet, please consider joining. We have a membership table over there. You can see Nancy and Hope. Or just come down to our clubhouse down at the lake next to the Athenaeum. We are a welcoming community to all, and that is why we are known as the heartbeat of Chautauqua. Today, I'm honored to introduce you to Dr. Jonas Johnson. He will talk for approximately 45 minutes, followed by 15 minutes or so of Q&A. After his talk, please queue up to one of the 2 mics. Please, only 1 question per person to allow others a chance for their questions, and please refrain from asking follow-up questions. Thank you. Now on to Dr. Johnson. Before I go on, I'd like to publicly thank George Fector and Chrissy Fulton for making the introduction to our esteemed speaker today. George and Chrissy act as a great resource for speaker referrals. They are lifetime members of the Women's Club and huge supporters, so thank you. They also helped underwrite Dr. Johnson's visit to Chautauqua. I do want to say thank you, though, for increasing my vocabulary. I now know how to say otolaryngology. I'm grateful to you both. Now on to Dr. Jonas Johnson. I will also say that he contributed a few words to his bio, and they're very, very humble. I'm following his lead, but you have done great things, and he will talk about them. So Dr. Johnson is local. He's a graduate of Jamestown High School, class of 1965. Welcome home. After completing college, medical school, and resident training in ENT, Dr. Johnson spent a short time in the U.S. Air Force. In 1979, he moved his family to Pittsburgh, where he joined the University of Pittsburgh faculty and the eventual UPMC. He He has dedicated his life to treatment of people with cancer of the head and neck. For many years, he was in the operating room. He served as editor-in-chief of leading ENT journals, and he has been the president of the American Academy of Otolaryngology, Head and Neck Surgery, and the American Head and Neck Society, as well as the Triologic Society. Dr. Johnson was appointed chairman of the Department of Otolaryngology at the University of Pittsburgh in 2005, which is world-renowned for its work. In 2016, he transitioned out of the operating room, and this has allowed him the opportunity to re-engineer his career. With Dr. Marcy Nilsson, RN, PhD, a program in survivorship at Pitt was established in 2016. This survivorship program acts as a cutting-edge model throughout the country. They have had over 4,000 visits. Many people are cured of throat cancer. The treatments, however, are toxic. This survivorship effort seeks to understand better what treatment-related side effects develop and to help people better navigate sometimes tricky healthcare system. So cancer survivorship is a topic of interest to all. Let's give a warm Chautauqua welcome to Dr. Johnson.
So thank you so very much for that very gracious introduction. And I'm delighted to be here. Actually, I'm flattered and honored that you've come to hear this. As was stated, Janice and I, my wife, grew up in Jamestown, New York. We actually graduated from Jamestown High School. And in 1965, we did get our diplomas in the amphitheater, where my wife was a valedictorian. Janice is here today. She is a Carnahan. And closer? Does this do better? Yes. Okay. So Janice is a Carnahan, and for those of you who are familiar with Jamestown over the last 100 years, you know that's a prominent name in the history of Jamestown, New York. So it's true that after graduating from Jamestown High School, I went to college, then I went to medical school, and then I became a resident, and then I went into the Air Force. At the time was sort of the tail end of the Vietnam War, and I was conscripted. But it was a good experience for me. I was down in Texas for that. And when all of this was finished, I packed my 3 little kids. Actually, our youngest child was 10 weeks old. And we moved to Pittsburgh, and we haven't left since. When I got to Pittsburgh, the Department of Otolaryngology was 4 people. We had faculty meetings in the men's room, you know. But over time, my senior partner and our chairman was a fellow named Eugene Myers, and Gene Myers and others developed a program which we believe is one of the top programs in the United States. We had over 40 MD faculty and some PhD faculty doing research. We have a training program of 25 residents. We train fellows to do subspecialty work in several subspecialties that we call part of otolaryngology. So this is things like voice and otology, pediatric otolaryngology, facial plastic and reconstructive surgery, and of course we train people to do head and neck oncologic surgery, which is what I've pretty much committed my whole life to. And you know, over time, the Department of Otolaryngology at Pittsburgh has been on the cutting edge of some incredibly innovative changes in medicine. So my partners, who are still there, have invented a way to take brain tumors out of your nose. So that's an intersection of remarkable technology, which of course requires lighted scopes, and then the development of instruments that are long enough and adroit enough to actually use in the nose or in the brain, because they go straight up through the nose and into the brain, and they take tumors out. So we call this endoscopic endonasal approach to cranial-based tumors. That's just a lot of words, but what it says is it's changed that field dramatically. And of course, it reduces the morbidity of surgery. It makes convalescence much more quick. It's minimally invasive. So these are incredible changes. Our department has been on the cutting edge of robotics. Okay? So when I was young, if we're going to take a cancer out of somebody's throat, we made a very large incision in the neck. And we take things apart, and we go in and we take out the tumor, and then we put it back together again. And you can imagine that convalescence from that kind of a procedure took a long time. And sometimes, well, you're not normal after that because you cannot go back to your pre-morbid situation. So it's wonderful that today we take tumors out through the mouth using robots. We have a colleague who works with us, and he runs what we call the Pittsburgh Hearing Research Center, who in the last decade has figured out why people have tinnitus. So tinnitus is that noise you hear in your ear that nobody else can hear. It's ringing. So we know today why people have tinnitus, and actually we are in the midst of trying to get approval to test an agent that will potentially help or cure tinnitus for people. The whole thing is, it's amazing, it's an amazing story, and I'm not here to talk to you about it. But I want you to know that there's a lot of interesting things going on in otolaryngology. And they change our lives, and they'll change the way medicine is delivered in the future. So part of the reason that our Department of Otolaryngology has been able to be this successful is that actually, historically, we came from an eye and ear hospital. The Eye and Ear Hospital of Pittsburgh was founded in 1895. And it gave us actually a lot of leverage to do a lot of things that maybe we wouldn't have been allowed to do in a general hospital. And we, at one point in the 1980s, we lost what was then an eye and ear hospital because actually we didn't need a hospital to, ophthalmology patients are not in the hospital at all. When you have your cataract taken care of, you go home same day. So the world has changed so many ways, but we have a sustaining eye and ear foundation. And our foundation has helped us fund our research for years and years. Because the way research is funded in this country is we get, government money, like from the National Cancer Institute or the National Institutes of Health. But if you want to do cutting edge pilot studies and try something new, you pretty much have to find your own funding. And so by having our own foundation, it's been remarkable. That's for sure how we've, for instance, made this progress with tinnitus, for sure. And it's amazing. So I've came today to speak with you about cancer. So, the cancer that we take care of in the throat, mouth, larynx, pharynx, the cancer we take care of in the throat develops on the surface, which we call the mucosa. But those cancers are caused by external carcinogens. When I was young, we were trained that it was caused by tobacco. But as I'll explain in a couple of seconds, it's very simplistic and it's not the whole story, not at all. What happens, on the mucosa is every day your cells are dividing. We call that mitosis. And if something causes a cell to have a mutation during its mitosis, the risk is you get cancer. So why do cells have mutations? Well, it's because they're exposed to carcinogens. And it's true, tobacco is a carcinogen, and if you smoke tobacco, you are at some risk. But we've, over time, learned that there are other carcinogens. The most prevalent carcinogen for people with throat cancer in 2022 is a human papilloma virus. I'm suspicious that most of you have heard of it, read about it, might even know somebody who has had an HPV-positive oropharyngeal cancer. That's what it is. This is a virus which is passed between each other. We get it from our friends. And this virus is very peculiar because for 98% of people, you get the virus, you have no fever, no sore throat, no rash, and it goes away. But for a small group of people, maybe 1 or 1.5%, it stays in your cells, and some years later it produces cancer. It doesn't produce cancer tomorrow or next year. In fact, it is estimated, although honestly nobody really knows, that it takes 20 to 40 years. So these people that you know with HPV-associated oropharyngeal cancer were exposed to a virus probably 20 or 30 years ago. And then it blooms and it causes cancer in your throat. This is the most prevalent cancer that we treat today. And in fact, oropharyngeal cancer, which is throat cancer, is more prevalent than uterine cervical cancer, which is caused by the same HPV virus, except that the gynecologists have found a way to detect it early and treat it before it ever becomes cancer. So what we've learned in the last decade is that these squamous cancers of the head and neck are associated with over 50 different mutations. 50. So this is not just one cigarette or one HPV. It's a whole list of different mutations that causes the cancer to proliferate. And if today you asked me, could I have caught the cancer from my neighbor's wood stove, or my guy across the street who's doing welding, or you name it, the paint? The answer is, I don't know. I mean, honestly, doctors don't know anymore. They never knew, but they thought they did. It gets back to 50%. 50% of everything you know is wrong. You just don't know which is the 50%. But at any rate, there we are. We know. Now, it's true that all of these mutations are what is behind the excitement about immunotherapeutics. So for sure, you've seen the ads, Keytruda, Opdivo. You've seen the ads about the new immunotherapies. And well, the idea of the immunotherapies is to target the specific mutation that caused the cancer, and you turn it off. But as I said, it's more complicated than meets the eye, because there are so many mutations. And so all I can tell you is in the world of oncology, we're working on it. Now, during my career, we in the 1980s and the 1990s took cancers out. We like to think that we healed with steel, since we're Pittsburgh. And we did heal with steel. We took so many cancers out. And then by the late 1990s, technologies had changed. And it became possible to treat people with radiation therapy more effectively than they had in the first 100 years since Marie Curie introduced that to the medical field. And it's possible today that you can cure some cancers with radiation with no steel, no surgery. And then we discovered that if you add chemotherapy to a radiation therapy, the irradiation was even more effective. So I have to tell you that certainly as a young doctor, our entire focus was on cancer control. That's what we wanted to do. And we treated people sometimes with surgery and then irradiation, and sometimes with surgery and then irradiation and chemotherapy. Some people skipped the surgery and just got irradiation and chemotherapy. But you see what I'm saying, that people were getting an awful lot of treatment. And this left us with a situation that I'm trying to address today. And that is that we have a whole population of people with throat cancer who have been cured, but then must live with the burden of treatment-related toxic side effects. So here's kind of how my story goes. In roughly 2014, when I was still actively engaged as a surgeon, I met a PhD nurse. Her research and her PhD was in clinical trials. And she was trying to do a clinical trial, and so she came to my office to recruit patients. And after a few months, we were discussing the toxicities that we were seeing in my patients, the horrible stuff that people were living with. And Marcy Nielsen said to me, there is a movement that was described by the National Academy of Medicine called survivorship. And survivorship is, I would describe it as a more contemporary approach to helping people who are cancer survivors. So what doctors like me have always done is we provide surveillance. So that means we do checkups. You know about checkups. You go see your doctor, he makes sure that the cancer's gone. Number two is we try to prevent people from getting a second cancer. It's more difficult than it sounds. It's a huge problem. 20% of people with one cancer get a second cancer. But the way I think you can prevent cancer is avoid tobacco, exercise, avoid being overweight, have good nutrition. So that's kind of the prevention world in a nutshell. But what was different about the survivorship program being espoused by the National Academy of Medicine was that what we needed to do was a better job of understanding what people are suffering with. So that seems stupid, maybe, but here's the way it would go. When Jonas Johnson would go in to see his patient in 2015, I'd say, "Hello, Mrs. Smith, how are you?" And she would say, "I'm fine." And I would pat myself on the back and say, "See you later." Okay, you get it. You're laughing because it is laughable. So there are available what we call patient-reported outcome measures, PRO or PROMs. And what a patient-reported outcome measure is, it's a questionnaire that has been validated in groups of patients to demonstrate that it actually, in a subtle way, will indicate what's wrong with one group compared to the others, PROs. And it's pretty apparent that if you really want to know what a patient is having a problem with, you have to, in a systematic way, ask the right questions. You have to. It's not enough to say, "How are you?" So Marcy and I looked at each other, and in 2016, we established this clinic for survivors. Now, as it happened, that's when I turned 70. So that's when I stopped operating, because I did it actually because I thought it was a responsible act of a senior surgeon to stop. It's because I didn't want anybody to ever ask me to stop. And actually, it's because I thought I had surgeons in the environment who should stop. So I did. And once in a while, somebody says, "Well, how did that feel?" And I can tell you honestly, I had a great sense of loss. I would prefer to be 35. But, that just isn't in the docket. So what we did was we got some iPads, just tablets, and we loaded these iPads with questionnaires, which we call PROMs. So we had a questionnaire on quality of life. The interesting thing about this QOL questionnaire is it has 16 questions, and it asks, which symptoms have bothered you in the last 7 days? So I don't care what you had 30 years ago or last year. I want to know what's bothering you now. Quality of life. We ask people about anxiety and depression. So before I go any further, I'll tell you that roughly 20% of our patients are affected by anxiety and depression. For sure, it's a huge problem. People commit suicide, even though they're cured of their cancer, because they can't stand what's left. It's true. It's troubling. We ask people about swallowing. We ask people about neck disability, because we have people who never had surgery, but they find that their neck is stiff. and they get cramps in the middle of the night. It's treatment related. It's from your irradiation. We've had people who have had irradiation and they can't turn their head, so they can't drive. And then what we've done is we've actually measured the range of motion and the velocity of motion of the neck. And it's true. Their neck doesn't turn very well, and it doesn't turn as well as it did previously. It's really true. So how does this happen? Well, the irradiation makes stuff stiff. It makes your muscles stiff. And this fibrosis, this scar, which is induced by the treatment, only gets worse with time because it doesn't go away. It stays with you. We ask people about oral health. And actually, over time, we've asked people by a litany of things. So, for instance, we've asked about financial toxicity. You know, it's toxic to be sick. Now, it helps if you have too much money anyway, because then you won't maybe experience this toxicity. But you know that roughly 48% of Americans do not have $2,000. They don't. So if they have a catastrophic problem, like their hot water tank blows up or their car won't start, or they get sick, they can't afford it. And sometimes, once you have cancer, you can't go back to work. And sometimes, once you've had cancer, your bills don't stop because your doctors keep saying, come in, get a checkup, get a PET scan, get a CAT scan. I mean, that's financial toxicity. And of course, it affects the people who are least able to deal with it. We've been interested in caregiver burden. So this is pretty straightforward because most of my patients are accompanied by somebody who cares about them. And it's hard to have a loved one who's sick. It's hard. And, you know, so how can you help? I mean, those are the things we wanted to understand better. We have struggled with what we call health literacy, because it turns out that something between 20 and 40% of the population will willingly tell me they don't know what's going on. It's true. So I think that in this audience, we probably have only a few who may be suffering from financial toxicity of illness. And I expect your level of health literacy is amazing, but in the general population, that's just not the way it works. In the city of Pittsburgh, it's just not the way it works. So when we started our clinic in 2016, what I did was I went over to the School of Dental Medicine and talked to the dean, and I borrowed a dentist. And I went to the Physical Medicine and Rehabilitation Department, and I got a physical therapist. And I have a swallowing therapist who works for me. We went over to the School of the Western Pennsylvania Psych Institute, and we got a behavioral health person. I mean, we got those people. And then what we did was we set them up in my clinic, where we have 7 rooms and 1 hallway. And we developed a clinic where patients could come in, and in one visit, and in one clinic, they could see all 7 of us if they had to. And in fact, we only charged them once. And the reason for that was I thought that if people were suffering from financial toxicity and we tried to charge them 7 times, we'll never see them again. If we want to help, we obviously have to be affordable. So that's the way it went. And that's the way it got started in 2016. And it's true, by now we've seen 4,000 people. And it's true that since 2016, we have 250,000 bytes of information from these patients through their PROs. And, you know, that's been amazing because my sort of motto as a surgeon and as a teacher has always been to research something and then take what you've learned and educate the other doctors and advocate for change. Research, educate, and advocate. So Kelly was right that we were the first ever clinic like this, not only in the United States, but the world. And last month, Marcy sends me an ad from New York City. Mount Sinai, they're having a course in survivorship, and she was angry because they don't know what we know. And I said, Marcy, this is what we want. We want everybody to emulate this. We want them to do it everywhere. They have to. Because this is contemporary treatment of throat cancer patients. So here's what we do. When you arrive in my clinic on Thursday morning, what we do is we hand you a tablet. And since COVID, we give you the tablet in a room. So you don't have to be in the waiting room. You shoot straight into the room. And when you're done with the tablet, then what we do is we test your hearing while the nurses are downloading and scoring the PROs. So we read every response before we see the patient. And I know my doctor doesn't. I mean, he makes me fill out those stupid things, and I know he's never looked at them. But we do it because what happens while our nurses are downloading the tablets, we have a lady who's an audiologist. She goes in and she tests hearing. So you might say, why are you testing hearing? So actually, I have to acknowledge that I don't know why, except that the chief of the audiology group came to see me and said, Jonas, you should test hearing. I said, why? She says, don't you care if people hear? I said, well, maybe you're right. Anyway, so we do a screening audiogram on everybody. Many people have hearing aids that either the battery is dead or their wax is in their ears or their hearing aids just not working. We fix them. And then there's a whole other group of people who just can't hear and they prefer, they don't know they can't hear. We reported, and it's in the literature now, 75% of our people flunked the screening audiogram. It's staggering. And is it all treatment related? Well, I don't think so, because hearing loss is in large part due to our noisy environment. It's where we live. You know, and noise doesn't have to be guns. It doesn't have to be a factory. There's noise in the band, in the orchestra. There's noise all around us all the time, and it, of course, causes hearing loss. So 75%. So when we've done scoring these PROs, the nurses and we usually use 2 nurses so we can keep moving. The nurse will brief me and say, you know, Mr. Smith has reported the following problems. And then the nurse goes in and talks to the patient and says, well, I see you have pain. Where's the pain? How bad is the pain? How often do you have the pain? And what do you do about it? And, oh, I see you're having trouble swallowing. Well, tell me about your swallowing. Can you swallow liquids? Are you having trouble with pills and dry food? Have you had aspiration pneumonia? Okay? And then once the nurse is done talking to the patient, the nurse and I decide how the rest of the visit will go. And a visit in my survivorship clinic sometimes takes 2 hours, because if you're going to see all these people, it takes a while. And we try to tell people ahead of time, so this is actually not a surprise. And almost the only complaint we've ever had is the parking. They don't like, yes, thank you very much. So at any rate, we've been doing this for since 2016. We are doing this clinical research. We're trying to educate the community of head and neck or throat cancer oncologists, you know, radiation oncologists, medical oncologists, surgical oncologists. We're trying to educate, and we're trying to advocate for change, and we're seeing it. Everywhere across the country, my colleagues are trying to do what we're doing. So the biggest problem is that if you use the model I've been using, we lost $350,000 last year. So that's because we have all these people and we only charge one fee. And well, the way we've gotten along, as I told you, we have this incredible foundation. So we have grateful patients. They've helped us a lot. Lots of grateful people. There's foundations in Pittsburgh that have helped us a lot. I mean, I won't name them, but there's 4 or 5 that have given us significant contributions to make this happen. And then as I got to the end of my career, because now I'm going to no longer be chairman, I made a deal with UPMC to fund us also. So we're going to be okay. We'll continue this. But Jonas Johnson understands that to make this sustainable across the country, what we need to do is to demonstrate that by helping cancer survivors, by helping them. So this is the way I think about it. Once you're treated for throat cancer, you actually have a chronic problem. The most prevalent problem is swallowing, but people have oral dryness. That's from the irradiation. You know, they don't have enough saliva. Some people can't taste. Some people have pain. I mean, it just goes down the list. People are left with a chronic condition. So what we need to do is demonstrate that we can help people navigate a very difficult healthcare system if they have a longstanding chronic illness. Funding in the United States for healthcare is overwhelmingly focused in inpatient care. And we need to focus on preventive care or chronic care. And to have a person who's been radiated or had surgery for throat cancer go to the emergency department is complete waste, because they get to the ED and they'll say, well, you should go see your doctor, don't come to the ER. And it's true. So what we try to do is have people understand that, and then we have tried to put together a team so when people need help, we can help them. And all we do really is we help them navigate this crazy healthcare system we call ours. We help them find the right doctor, go to the right place, get whatever it is they need. And you see, if they did that, then we'd save money for the insurance company. We'd save money. There's just no doubt about it. In fact, the UPMC health plan, which has helped us a lot, sees it. They know that we're saving them money. We keep people out of the hospital. We spare them unnecessary stuff. So that's the first step. The second step is we are clearly improving quality of life. And that's appealing, except it doesn't have a dollar sign attached to it. So I hate to expose my cynical worldview, but I understand that to get funding for survivorship, we have to save money. So we save money by preventing unnecessary care, by preventing going to the ED, by preventing unnecessary hospitalizations. The last thing is, and we do improve quality of life, the last thing is that if you have throat cancer, and if you have dysphagia, which means you can't swallow, and if your dysphagia gets worse over time, which it often does, then what happens is you begin to aspirate, you get pneumonia, and your life is shortened. We're going to prolong life if we do this right. So those are our goals. That's what we're trying to do. And of course, we're trying to research. We're trying to educate the community of doctors across the country and around the world. And then we're advocating for change. That's what we're trying to do. So when I turned 70 and quit operating, I had this opportunity to re-engineer my life. I actually, well, the message I got from home was, for better or worse, in health and illness, but not for lunch. So here I am. I still go to work. So thank you very much. I'd be delighted to answer your questions.
So please come up to the microphones.
Yeah, hi. I'm Mike. Is it on?
You're Bill Bates.
Yeah. Yeah, we know each other. Same club. How are we doing with the prevention? And a second part of that is, how are we doing in these areas versus the rest of the world?
So I know you must have heard George speak about HPV and the availability of the HPV vaccine. So the guy who first identified the oncogenic properties of this human papillomavirus was a German, and he did it in 1983, for which he got the Nobel Prize. But his research identified the HPV as causing uterine cervical cancer. And shortly thereafter, Merck and then others developed a vaccine, and that vaccine has become increasingly effective, and of course it's safe. It wasn't until actually 2006 or so that the powers that be figured out they should give it to boys too, because apparently they figured HPV was only passed from woman to woman. I don't understand where they got that. It's so dumb, but that's exactly what happened. So today, the HPV vaccine is available. It's safe. They recommend getting it when you're 11, although you can get it up to your 46. And then and anybody who is not in a 100% monogamous relationship should get vaccinated. And then the last thing is we live in these strange times when a vaccine is characterized as being evil by some percentage of the world. I don't understand that, Bill. But George and I went to the Allegheny County Board of Health. This was years ago. I don't remember when, let's say 2017 or 18. And we asked them to make a vaccine for HPV mandatory for 7th grade, which would not be too shocking because there's already 16 vaccinations necessary to go to school in Pittsburgh, Pennsylvania, 16. And we had a bunch of anti-vaxxers show up that were frightening. They were frightening. Yeah, so, and then I don't have to tell you what's happened in the last couple of years. Anybody who's got a newspaper knows. So the vaccine is out there. Responsible people are getting their kids vaccinated, and the others are going to get cancer. Yes, ma'am.
I was wondering, what mechanism with your team if the cancer becomes incurable? Do you then refer to a hospice and palliative program? Do you work with them in the beginning?
So that's a really, really complicated question.
Yes.
We unequivocally see people who have cancer that has not been controlled. You know, they have metastatic cancer in their lungs or other places. They're obviously dying. There are these immunotherapeutics out there that have some reported efficacy, but you know, the best are 15% effective. There's nothing that's like a silver bullet. So, you know, what we try to do is get people in the right hands or the right places, you know, so they get the support they need. And that is also sometimes complicated. But we've developed quite a network of behavioral health people, palliative care people across Western PA. So I'd say we're doing better. I would never declare victory. You know, these are tough problems.
Yeah, good afternoon, doctor. I really don't understand this, but if you have cancer, say in the lymph system or in the circulatory system that goes into the brain, do you necessarily have to have cognitive loss, or is there a treatment for that, or do you know what part of the brain it goes to?
So that is a complicated question because the brain is a very complicated place, and what symptoms you have will depend on which part of the brain is affected, for sure. And then, of course, it'll depend on if there's an effective treatment. So, you know, sometimes they can use special focused irradiation to treat brain metastases, like you've probably heard of the gamma knife or the cyber knife. And they call it a knife because it's so focused that it just treats a very small area. So some things can be controlled or palliated, but it's a challenge. Yeah. It would be better to get the vaccine and not have the cancer in the first place.
Yeah, thank you.
Yes, sir.
I'm Khalid Rahman. I'm a medical oncologist, retired. I want to thank you for shedding a light on survivorship because I think it's a very important issue. And if, with your permission, if I may just reiterate and reinforce some of the things that you have said in general, because you have focused mostly on head and neck cancer. But for all cancers, those patients who have been treated and have recovered or hopefully cured, they need to be followed for a long period of time. And like me, medical oncologists, there aren't many of us around to take care of increasing load of cancer patients. So my suggestions to you is that, of course, if you are in Pittsburgh, you can take advantage of this wonderful clinic. But in your own communities, I will encourage you to talk to your primary care doctor, because they are partnering with the cancer doctors to develop a program of survivorship. There are things that they can do that you don't need to go back to the cancer center or to the oncologist. And there is a whole course available now that they can access. There's something called, if you can make a note of it, called NCCN, National Cancer Care Network. There is a whole guidelines as to what to do with breast cancer, lung cancer, colon cancer, those who have been treated and cured or are well. So those guidelines are available. How often to do a scan, how often to do a chest x-ray, when do you do this? And this way they will follow it along with the cancer doctor so that you will stay in good health. Your side effects will be managed. If there's any pain and if there's any risk of second cancer, it can be detected. So more and more people are living with cancer, longer with cancer. When I was treating colon cancer, nobody made it for more than 2 years. Breast cancer, maybe 5 years. Today, I think every woman with breast cancer is living to at least 20 years. It comes back, you treat it, gets better. It comes back, you treat it, gets better. And so I think this issue of survivorship and living longer with the disease or even without disease, but the fear of disease, it is very important. So speak to your primary care doctors. They can talk to the cancer doctors, and there is a whole kind of a detailed programming that they can access as to what to do for you, for your particular cancer, so that you can be followed and you can remain in good health. Thank you.
Thank you. Very nice. Yes, ma'am.
This may be a dangerous question, but if funding is such an issue for a clinic like yours, wouldn't Medicare for All or a national health care system improve accessibility to general health like a clinic like yours? Thank you.
You're going to really drag me out in front of the population, aren't you? Sorry. So I think that the majority of people I work with, you know, the doctors I work with, are really ready for national health insurance. We're ready. We're so tired of this. But I guess I haven't seen any change. So it's, again, it's enters into my list of things I'm cynical about. Yeah.
Jonas, I reside in two worlds. I love the time I spent as a volunteer and involved in the foundation leadership and academic medicine. The other world I reside in is right here, Chautauqua. We're approaching our 50th year of coming here. But I'd like you to speak to the subject of not retirement, but rewirement. And by rewirement, I'd like you to talk about how you made the decision to find this next stage in your career. And I say that not because we haven't talked about it before, but generally, whether it's at the coffee shop, whether it's at the women's club, a lot of us are looking at the subject of rewirement. That is, how we find purpose, how we make these adult years of our life, these next stage of our life meaningful. And I might ask you if you could speak to what that meant to you and what that might mean to others here.
So thank you, George. George and I have talked about this sort of ad infinitum, actually. I think it's difficult. As I got older, I became to sort of recognize my own mortality. I realized that there was no going back. We've made the "you can't go back to 35 again" joke already. I didn't have something that was compelling. I didn't want to play golf, because I spent my whole life with medical care, education, research. That's what I do. You could say, well, something the matter with that guy, but that's what I do. So the challenge was to ask myself what to do next. How can we do it? And I was offered this opportunity to re-engineer what I do because I could see a way forward. And, I actually have spent my whole career trying to change medicine. Try to get my colleagues who do what I do to see the error of their ways and do things differently. We change all the time. I mean, it's kind of a joke, but what I was taught in 1972 as a medical student is completely obsolete. I mean, I know the hip bone is still connected to the knee bone, but after that, there's all new medicines, there's all new equipment, there's all new ways to test people, like with imaging. We didn't have CT scanners in 1972. Today we have PET scanners, we have all this crazy stuff. Everything is changing, all the instrumentation is changing. We talked about robots. So the world is about change. And so I was looking for opportunity to continue to contribute to what is my world, which is throat cancer. I wanted to help my colleagues around the world be able to help their patients in ways that they hadn't done before. And I could see this way forward. So that's what I'm doing, and I'll do it until they're all doing it, and it looks boring, and then I'll try to find something else to do. And then I can't get away from this. They say, why don't you play golf? Well, when I throw a ball, the dog gets it.
I want to meet your dog. My beagle won't do that. I work with nonprofits that focus on systemic change and best practice development. I'm curious about two things. One, the ways in which you have come to understand a return on investment with your project. Have you been able to successfully define that beyond the very narrow terms of physical viability? Related, what perspective can you give us about what it means to put a best practice in place, the replicable model? What are you learning about how this beta piece gets replicated nationally and globally?
So those, of course, they're essential questions. And again, I understand cynically that the most important questions are economic. So the good news is that what's eventuated here at the end of my career is that everything is electronic. All the hospital data, everything's electronic. We have big data today. So at UPMC, we have big data. And we have data that shows that going to the survivorship clinic reduces hospitalization, okay? And in fact, during treatment, we reduce hospitalization by 15%. And it's huge. It's huge savings, huge. So we're working on data because obviously we need data to talk to our colleagues and to talk to people around the country and the globe so they understand why this kind of a program makes sense. And so that's what we're trying to do, for sure, yeah. Yes, ma'am.
Hi there, thanks for this. Curious about the partner or the patient-doctor relationship in terms of looking at the surgery ahead, whether or not you partner with people who say, based on you're giving them information about the downside of the disease process, the surgical process, the chemo. I just was very curious about, are there patients who say, thank you, no, I don't think I'll take it?
So, great question. One of my interests in the twilight years of my career has been to help patients and doctors avoid what we call low-value care, okay? So low-value care is, it's been cleaned up. Jonas was calling it futile care, and they told me don't use that word. But why would you offer a patient something that won't work? And, you know, this business, healthcare is peculiar because the first thing they taught us in medical school was don't say never. Don't say never, and of course you don't say always either, because there's something unpredictable about health. It's unpredictable. You can't say always and can't say never. So, but you have to be more practical about it. So if you have a patient who cannot recover from a major surgery, why would you recommend a major surgery? And so we've put in place tools to measure frailty and centers for pre-surgical care to try to help patients and their families and their doctors, to be honest with you, understand they can't recover. And if you have an incurable cancer, and they exist, why would you have a big operation or go through all this treatment? Why? Because, honestly, this has been published. If you ask normal Americans, if you were told that you will not live a year, would you have an operation? The majority say, absolutely not, I wouldn't do it. So why do doctors and patients get into this? It's crazy. So I agree with you. So we have all kinds of things we're doing to try to help patients and their families understand the potential for benefit from an intervention and the potential for harm, because almost everything is potentially harmful. And then I do have patients who say, no, thank you, for sure, I do. They tend to be older people who are potentially more, I think, philosophic toward the end of their life, and they say, I'm not doing that. And I say, sounds like a good decision to me. I wouldn't do it. And actually, when they do surveys, the doctors and the nurses say they wouldn't do it, but the patients are doing it. See, so the doctors and the nurses, they know it won't work, but the patients are doing it. I mean, so this is nuts. It's nuts. So I would like to see this change, for sure. And, I'm a guy who lived as a surgeon for the last 50 years. And my MO was to get up in the morning, have a problem, and fix it. And when I got into the business of avoidance of low-value surgery and low-value care, when I got into the business of all this other stuff, it was so frustrating because I didn't fix anything. I'd get up in the morning and spend all day and go to bed, and it's still not fixed. It made me nuts. I mean, seriously. The velocity of change is so slow. But I have the feeling that you have to keep talking about it.
Thank you.
Yes, ma'am.
Am I allowed to ask a question? I am. Presidential privilege. So you said a few nuggets to me before we started, and my nephew had neck cancer, and he was 36, diagnosed, and it was with the HPV. And it was the worst treatment ever. And when I told you that he went to a doctor, and the doctor, he found a little lump, and the doctor gave him antibiotics and sent him home. And I just want to leave everybody with this last nugget. You said adults don't get lumps. If you find a lump, get a biopsy. So I just think that's a really wonderful way to leave today, that we just have to be advocates for ourselves and make sure that when something isn't right, you do go to the doctor. And hopefully, if God forbid you do get cancer, you go to a survivorship clinic just like this one. So thank you very much, Dr. Johnson.
Yeah, thank you, Doc. Just a quick question. I live in California, and they passed the Death with Dignity Act. Where would that occur when you're painful? Where would that occur in a treatment, and would you participate in that, where the doctor helps you in your life?
So, we like to think that all of us in the healthcare professions commit ourselves entirely to helping people make good decisions. And I think it's hard to legislate. It's really hard. So I don't know how to make it perfect. Historically, the American Medical Association in 1847 actually had a proclamation that said that patients should do what their doctors say, 1847. So then fast forward to the 1980s, and they had a convention in Belmont, where they said, patients have the right to say no. In fact, they're in charge. And what's necessary is they need to be informed. And they should be informed in such a way that they can make a decision and that they can say no, and it's okay. Well, fast forward one more time to our contemporary age. And doctors today should understand what shared decision-making is. But basically, the short story is that patients who have illness need to have enough information to make good decisions for themselves. The doctor does not make the decisions for them. And I know that I have plenty of patients who would prefer for somebody to make the hard decisions. They say, well, what would you do? What would you do if this was your wife? Those are difficult. But the real job, I think, of all of us is to spend enough time with patients so they and their families understand what's at stake, what are the potentials for benefit, and what are the potentials for harm, and they can make good decisions, shared decision-making. Thank you.
Thank you all for coming. Enjoy your weekend.